Hello, is audio okay to everyone? Just tell me in comment section. Hello everyone. Is audio okay? Then give me a thumbs up. Okay, Venki. So today lecture is all about pseudobulbar and bulbar palsy. Because in in this our Harrison based series, na, we have many times encountered pseudobulbar, bulbar. Because in our last class of dementia, when we are dealing with small vessel disease which are doing dementia. So there have also got to know that in small vessel disease there is something known as pseudobulbar palsy. And our next topic actually was aphasia. But before we move on to aphasia, first we should clear our concept on what is pseudobulbar and bulbar palsy and what is the difference between multiple sclerosis and small vessel disease because both are white matter disease. So many students were having doubt in this. So before we move on to aphasia part, we will first see what do you understand by pseudobulbar and bulbar palsy and how we can clinically differentiate between the pseudobulbar and bulbar palsy. Okay, everyone. So shall we proceed? See, we are now starting with the pseudobulbar and bulbar palsy. Okay. So what do you mean by bulb? Anyone? Can anyone tell me what do you mean by bulb? What do you understand by term bulb? So basically, when we are saying it is no, Shri, it is not nucleus. So yeah, Shri, today we will also discuss about that. You are having last time doubt on multiple sclerosis, small vessel disease. We will also discuss that topic in this class also. Okay, Shri. So, bulb means your medulla. Bulb means it's your medulla. And now we are studying a topic that is your bulbar palsy. Okay. So, what do you understand about bulbar palsy? The cranial nerves. The cranial nerves. The cranial nerves which leaves from medulla, the cranial nerve which leaves from medulla, and especially their motor component because cranial nerves have both components, sensory and motor. So especially their motor component. So cranial nerves which leaves from medulla, their palsy is there. Their palsy is there. So bulb means medulla, and bulbar palsy means cranial nerves which leaves from medulla, their palsy. So just tell me in comment section which all cranial nerves leaves from medulla. Which all cranial nerves leaves from medulla. Just tell me in comment section. Which all cranial nerves leaves from medulla. Anyone? Series like 9, 10, 11, 12. Okay. So your 9, 10, 11th, and 12th. An easy way to remember is that this is your midbrain, then comes your pons, and then comes your medulla. Hello, Dr. Vipul Kumar. How are you? Yeah, Dheeraj, you are right. 9, 10, 11, 12 cranial nerves. So this is your midbrain, then your pons, and then your medulla. From medulla, third and fourth nerve. From pons, it is 5, 6, 7, 8. And from medulla, it is 9, 10, 11, 12. So that's an easy way to remember. Okay, everyone? Yeah. So here we are dealing in bulbar palsy. So bulbar means medulla. So cranial nerves which leaves from medulla, they are damaged. And what can be the pathology that this cranial nerves which leaves from medulla are damaged? What? Yeah, Rishali, good evening. So thank you, Dr. Vipul Kumar. So bulbar palsy means bulb is medulla and palsy means cranial nerves which are living from medulla. Okay. So how can this cranial nerve will be damaged? When there is damage to medulla. When there is damage to medulla. When there is a damage to medulla. When there is damage to medulla. Maybe a medullary stroke or mass or tumor in medulla, which is leading to the damage of medulla. And if anything is damaging medulla, it will also damage the cranial nerves leaving from medulla. It will damage the cranial nerves of medulla. And then we will call this term as your bulbar palsy. Your bulbar palsy. Okay, everyone. Shall we move forward? So this you mean by the term bulbar palsy. So see, now we'll draw a cut section of a brain. Okay, this is your midbrain, this is your pons, and this is your medulla. And which nerves are originating from here? These are your ninth nerve, your 10th nerve, your your 11th nerve, and then last is your 12th nerve. Last is your 12th nerve. So all these nerves are living from here. Okay, everyone. Now see. Now, can anyone tell me the function of 9, 10, 11th, and 12th cranial nerve? What do you understand by the function of 9, 10, 11th, and 12th cranial nerves which are living from medulla? Anyone in comment section? What is the function of your 9th, 10th, 11th, and 12th cranial nerve? Can anyone tell me which part of your pharynx is innervated by 9th nerve, 10th nerve, and which part is innervated by 11th nerve, 12th nerve? Okay, good, Shri. They are used for swelling. Okay, good. So when we come to your this, see, when we come to this is your ninth nerve. Okay, Shri. Your ninth nerve basically innervates your pharynx. Basically innervates your pharynx, and that is your stylopharyngeus muscle. That is your stylopharyngeus muscle. Then comes your 10th and 11th nerve. your 10th and 11th nerve, they both combined. The 10th and 11th nerve, in their due course, they both combined and they innervate your pharynx, your larynx, and your soft palate, and your soft palate. Then comes your 12th nerve. Then comes your 12th nerve. And your 12th nerve, it innervates your tongue. It innervates your tongue. So your ninth nerve innervates your pharynx. And pharynx, there is your stylophalangeal muscle. Yes, Shani. Then comes your 10th and 11th nerve, which innervates your pharynx, larynx, and soft palate. Then is your 12th nerve, which innervates your tongue. Now see, we are seeing this diagram. In this diagram, this is your medulla. Okay. From medulla, you can see this ninth nerve is living, this 10th nerve, this 12th nerve, and this is your 11th nerve. They both are living from medulla. And after leaving medulla, where they are going? They are going to your, see, they are going to your tongue, they are going to pharynx, they are going to larynx. Okay. So they are going to tongue, your larynx, and your pharynx part. Now, if we see this diagram, in this diagram, we have understood that this 10th nerve and this 11th nerve cranial part, this 11th nerve cranial part, okay, they both combine. They both combine. So 10th nerve and 11th nerve cranial part, in their due course, they both combine. Okay. Then in your medulla, there is a special nucleus. In your medulla, there is a special nucleus. There is a special nucleus. This is known as your nucleus ambiguous. This is known as your nucleus ambiguous. This this is your nucleus ambiguous. It gives supply to, yeah, this gives supplies to your ninth nerve. It gives innervation to 10th nerve, and it gives innervation to your 11th nerve cranial part. And there is some other nucleus also. There is another nucleus sitting here. This is your hypoglossal. This is your hypoglossal nucleus. Okay, everyone. And this is giving supply to your 12th nerve. Okay. So from medulla, four nerves are coming. Your 9th, 10th, 11th cranial, and 12th nerve. This 10th and 11th cranial nerve, in their due course of time, they both combine. First thing. Other is your 9th, 10th, 11th nerve. Both these three nerves have innervation from a common nucleus. That is your nucleus ambiguous. So this is your nucleus ambiguous, which is innervating these three nerves, 9th, 10th, and 11th nerve cranial part. And your 12th nerve is getting innervated by a other nucleus, that is your hypoglossal nucleus. And this all nerves, where they are going? Your ninth nerve is going to pharynx. Your 10th nerve and 11th nerve is also going to pharynx, and your 12th nerve is going to tongue. So these nerves, in their due course of time, they are also known as your brachio brachiomotor fibers. Brachiomotor fibers. Why? Because they are innervating your pharyngeal muscles. Because they are innervating your pharyngeal muscle. So these 9, 10th, and 11th and 12th nerve, they both innervate your pharynx, tongue, and soft palate. And we all know what is the function of tongue, soft palate. They help in your swallowing purpose. They help in sound purpose. So if these nerves are damaged, there will be problem in your sound. Articulation problem will be there. There will be dysarthria, dysphonia. There will be dysphagia. Difficulty in swallowing will be there. Nasal regurgitation can be present because this 9, 10th, and 11th and 12th nerve, They all carry brachiomotor fiber because they innervate your pharyngeal muscle. So damage to this nerve will lead to difficulty in swallowing, difficulty in producing sound, difficulty in producing, difficulty in dysphagia, difficulty in moving tongue. Okay, everyone. Now, now we all know that you have a structure known as your larynx. You have a structure known as your larynx. Yeah, Shri, gag reflex also. Your gag reflex or your cuff reflex also. Yeah, Shri. So we all know that we are having a structure that is your larynx, and larynx has your vocal cords. Larynx has vocal cords. So when I when I'm expiration, when I am doing expiration, air is coming out from my respiratory system, and it is going through larynx. Through they are coming out from larynx. Then there is vocal cord. Then they are coming out. The air is coming out. So if yeah, Runpal, what are you asking? I'm not understanding, Arun. So yeah, after consulting psychiatrist, you can do this. हाँ मेडिसिनल क्लास ले सकते हैं एस ए आर ऑफ पैरासिम्पथेटिक you are saying to me that I should explain parasympathetic and sympathetic nervous system to you. So I was telling about larynx. So when I okay Arun, I will take a class on just tell me the topics in matlab, in which you want the class because basically our classes our class is all about that Harrison based discussion. We are going Harrison chapter wise. But if you are having doubt in any other source, it's just tell me in comment section. We will plan class for that purpose also. Okay, Arun Pal. So so first we have to produce a sound. So for producing a sound, we have to do we have to expire first. This air will go through larynx. Okay. And for when you produce sounds, your vocal cords are closed. When you produce a sound, your vocal cords are closed. Your vocal cords are closed. ठीक है अब when you are when air is blowing out from larynx and vocal cords are closed, so this air will hit the vocal cords and it will produce a sound, and it will produce a sound it will produce a sound. Okay, and it will produce a sound. Now this sound this sound with the help of with the help of your tongue, your soft palate, your lips will be converted into words that are meaningful, words that are meaningful. Because a 1 year boy can also produce song, but he can't produce meaningful words because he don't know how to use tongue and soft palate and lips to manipulate the sound such that words are formed. To manipulate the sound such that words are formed. But we adults we know how to use our lips, our tongue and soft palate to the sound which are producing such that it get converted into words. Okay, so how we are able to produce word? First, there is a production of sound when we expire because at the time of inspiration we can't say. when you are inspiring air, you can't say. You say when you expire. So when you expire, yeah, that air goes through larynx. Through larynx, it go to vocal cord. It hits the vocal cord because vocal cords are closed. And when you are hitting the air in the closed vocal cord chamber, a sound is produced. A sound is produced, and this sound, when traveling through your oropharynx and nasopharynx and pharynx part, it get manipulated with the help of your tongue, with soft palate, with lips, and it leads to production of a meaningful words. It leads to production of a meaningful word. Suppose I am saying larynx. I am saying larynx. So I am using my tongue, my lips, all. So I am producing my sound to a meaningful word. But a small boy, a 1 year kid, a 1 year boy, he can't produce meaningful words. He only produce sound. He doesn't produce words because he can't use his tongue, soft palate in a proper way manner. Okay. So now we all get to know that your 9th, 10th, 11th, and 12th, 9th, 10th, and 11th, and 12th, and we all know that your recurrent laryngeal nerve, your recurrent laryngeal nerve, it has a supply to your vocal cord. It has a supply to your vocal cord, and it is part of 10th nerve. So when there is damage to 9th, 10th, and 11th, and 12th nerve, there is problem in sound also. There will be dysphonia also. There will be dysphonia also. And there will be problem in word production also, because when there is production of sound, sounds is converted to word with the help of tongue and soft palate. But now your tongue soft palate supply is also gone. So there will be dysarthria because words can't be produced meaningful. And also the sound part, because it is produced with the help of vocal cords and larynx. But if your 10th nerve is damaged, so can you produce a sound? No. So there will be dysphonia also. So there will be dysphonia, there will be dysarthria also. Okay, everyone. Have you got this concept? Why there is dysphonia and dysarthria both are present when there is a bulbar palsy? Just everyone, if anyone having any doubt, just tell me in comment section. Have you got understood that how sound is converted into a meaningful word? How sound is converted into a meaningful word, and how the bulbar palsy can lead to dysphonia. It means sound can't be produced, and how it can lead to dysarthria. Okay, just tell me in comment section if any doubt. Anyone having any doubt till now, just tell me in comment section. Shall we move forward then? So we can say that your bulbar nerves, that your bulbar nerves, they help in phonation as well as anyone having any doubt till now, just tell me in comment section. And articulation also. Phonation is about your sound, and articulation is forming meaningful words. Forming meaningful words. Now see this diagram. This is your ninth, this is your 10th, and this is your 11th with the 10th nerve. And this is your 12th nerve. Okay. And here is your here is your tongue. Then there is your larynx part, then there is your larynx, and this is your this is your pharynx. Okay, they all are supplying these structures, and if they are used for they are used for swallowing, because you swallow with the help of tongue. You swallow with the help of your tongue and soft palate, so they help in swallowing also, and they help in articulation also. They help in phonation also, and we all know that tenth that we all know the ninth and tenth nerve also help in the gag reflex, that you cough whenever you are eating something, and that thing shouldn't go to your respiratory system. That thing shouldn't go to your respiratory system. So it is protected by your gag reflex. So you suddenly cough. So your gag reflex or your cough reflex. So if your bulbar system is damaged, if your bulbar system is damaged, your swallowing, articulation, phonation, gag reflex, cough reflex, all these things will be affected. Your all these things will be affected. Okay? So by this we mean that your articulation, your articulation and your phonation and your phonation are done with the help of 7th, 9th, 10th, 11th, and 12th. You will say, sir, you have said about bulbar nerves. You have said about bulbar nerves, that's in 9th and 10th, 11th and 12th. Why there is 7th nerve? Because your 7th nerve have a supply to your lips. 7th nerve have a supply to your lips. And your lips also help in formation of words. Your lips also help in formation of words. So if any of these nerves are affected, including your bulbar and including your 7th facial nerve, you will get a problem of your articulation and phonation. You will get the problem of your articulation and phonation. And when it comes to your swallowing, when it's come to your swallowing, it is your 5th, 7th, 9th, 10th, 11th, and 12th. Now you will say, sir, you have had this extra nerve 5th, because your trigeminal nerve, that is the fifth nerve, it helps in mastication also. It helps in mastication, chewing of food. If this is affected, then can you chew food? No. So it will lead to problem in your swallowing. So for articulation phonation, bulbar nerves plus 7th nerve. For swallowing, your bulbar nerves plus your 7th and 5th nerve. Okay, everyone? Everyone okay till now? Just give me a thumbs up if you understood till this now, articulation, phonation part, swallowing part. Anyone having any difficulty till now? Just tell me in comment section. Arun, Pal, Shiri, Sherni, anyone? Anyone having any problem till now? Shall we move forward? Arun, for which exam you are preparing, beta? Arun, for which exam you are preparing? Just tell me that. Then we will discuss about this. Okay. So there is one thing we should always take in consideration. What is this GPET? Arun, I don't know. Na? It is Gujarat. I don't know about GPET. Just tell me the full form. So generally, we have seen one thing. Generally, what happens? Generally, when your bulbar nerves, when your bulbar nerves, that is your 9th, 10th, 11th, and 12th, when generally these nerves are damaged, when generally these nerves are damaged, with these nerves, your fifth and seventh nerve are also involved. Your fifth and seventh nerve are also involved. Okay, because suppose there is a medullary stroke. Suppose there is a medullary stroke and these nerves are damaged. But it is not it is not always not stroke will be limited to medulla. Suppose this medullary stroke has gone to some areas of pons, so it will involve some nerves of pons also. It will involve some nerves of pons also. Because when we are saying in clinical experience, when we see patient clinically, it is not just confined to patient will have clear cut medullary stroke only. It will include some part of your below medulla and some part above medulla also. So if it involves some part above medulla of pons, sometimes we have seen that your fifth and seventh nerves are also involved. Okay, everyone. So so we have come to this conclusion that your bulbar nerves, your bulbar nerves helps in swallowing, helps in articulation, helps in phonation, and helps in your motor expressions of emotions also. Help in motor expressions of emotions also. Suppose I am laughing and there is some joke. So when you laugh, also there is a sound. When you cry, also there is sound. And every individual have a different sound when they cry and different sound when they laugh. So this manipulation of sound, when your emotions are there, it is also done with the help of your bulbar nerve because your tongue soft palate will manipulate that sound now. So everyone when they laugh, they have different sounds. Everyone when they cry, they have different sound. So this motor expression of emotions, this motor expression of emotion, because once there is some individual who laughs very much loudly and someone like hee hee. So they have different expression according to their emotion. So this thing is also controlled by your bulbar nerves. This thing is also controlled by your bulbar nerves. Okay. Yeah, Shri, that goes till medulla spinal glucose trigeminal. ठीक है. Now we have understood about bulbar palsy. We have understood about bulbar palsy that it affects the bulbar nerves. Now there is a term also known as your pseudo bulbar bulbar palsy. ठीक है. Now can anyone tell me what do you understand by the term pseudo bulbar palsy? By bulbar palsy we understand that medulla is damaged. What do you understand by the term pseudo bulbar palsy? Anyone in comment section can tell me what do you understand by the term pseudo bulbar palsy? It means it is not actually bulbar palsy. It is something pseudo. It is something fake. So what is this fake? Can anyone tell me? What do you understand by the term pseudo bulbar palsy? UMN. Very good. So this pseudo, it means this disease, this palsy is mimicking, is mimicking. It is mimicking the bulbar palsy. It is mimicking the bulbar palsy. So it will have many features like bulbar palsy, but they will be not that much severe. They will be not that much severe. So it is a palsy which is mimicking the bulbar palsy. That's why we call it as a pseudo bulbar palsy. Now, Dheeraj is saying it is a UMN lesion. Okay, very good. It is a UMN lesion. It is a UMN lesion. And so, what are the UMN tracks which are having? First is your corticospinal tract, and other is your, just tell me other UMN tract. One is your corticospinal tract, other is which tract? Other than corticospinal, which tract is your UMN tract? Other than the corticospinal tract, which tract is your UMN tract? Just tell me in comment section. Other than your UMN tract, which tract is your, that is your cortico nuclear tract? Yeah, yeah, good Shri. Or it is your cortico bulbar tract. So we all know the use of corticospinal tract. The your corticospinal tract, it goes to spinal cord. It goes to spinal cord. We all know. But what, Arun? Actually, I don't have idea about this exam, na, that much. But if you can tell me the topics which come in this exam, then I will surely help you about. Okay. If you tell me the topics in comment section which you want that I should discuss, then I will discuss that topics. Just tell me in the comment section. We will discuss that topic also. No worry. In my upcoming lecture, we will discuss that topic. Okay, Arun? So, CST test goes to spinal cord. Then, with the help of your lower motor neurons and nerves, they go to muscle. We all know. But what about this corticobulbar tract? What is the use of corticobulbar tract? Anyone can tell me in the comment section. What is the use of corticobulbar tract? We all know the use of corticospinal tract. It helps us in controlling muscle and fine tuning of these muscles. But what is the use of corticobulbar tract? For which purpose it has been designed by God? For which purpose God has given us this corticobulbar tract? For controlling the cranial nerve nuclei. For controlling the cranial nerve nuclei. Because in brainstem, your cranial nerve nuclei are there. And which from which nerves are coming? See this diagram. In this diagram, we are seeing that this is your brainstem. This is your brainstem. Okay. And from brainstem, these cranial nucleus are coming. This cranial nuclei are coming. So we need someone to control this cranial nuclei also, because we all know that element that, because when these cranial nerves, when these when when these cranial nerves are coming from base are coming from brainstem, they are like lower motor neurons. They are like lower motor neurons. But we need someone to control them, and we need someone such that they should be inhibited. They should be inhibited because you all know your human fibers inhibit your element fibers. So we need someone. And who is doing that process? That is done by a corticobulbar tract. So it controls it controls your element cranial nerve nuclei. Element cranial nerve nuclei. And it controls all the cranial nerves. It controls it controls all the cranial nerve nuclei except your third, fourth, and sixth. These are your these control your extra ocular eye movement. So your corticobulbar tract, it controls all the cranial nerve nuclei except your third, fourth, sixth, except your third, fourth, and sixth cranial nuclei. Okay, everyone. Have you got the concept of corticobulbar tract? Now see this diagram. we can see this corticobulbar tract is coming from cerebral cortex. From cerebral cortex, your corticobulbar tract is coming. And in this brainstem, which is your midbrain, pons, and medulla, this is one cranial nerve nuclei. This is one cranial nerve nuclei, and it is controlling this cranial nerve nuclei. And this cranial nerve, now it is your lower motor neuron. Rishali, we are coming on this topic also. That what happens when cortical tract are injured and damaged. We are coming to this also. So this is your cranial nuclei, and it appears as a element, and this corticobulbar appears as UMN. And this corticobulbar, it is inhibiting this cranial nuclei. It is inhibiting this cranial nuclei because we have studied in our last class of UMN versus LMN, lesion, weakness, and paralysis, that your UMN, with the help of your interneurons, with the help of your interneurons, they inhibit lower motor neuron nuclei. Okay? Now, now see this diagram. Now I am writing a statement. Just see. All the cranial nerve nuclei, cranial nerve nuclei in brainstem, in brainstem has a dual supply, has a dual supply from corticobulbar tract, from corticobulbar tract of each side, of each side, except except your your lower motor nuclei of seventh nerve and your hypoglossal, your hypoglossal nuclei. Okay, done. So what do we understand by this? I have told you in my last lecture of UMN versus LMN lesion that whenever you are getting hemiplegia, only one cranial of nuclear manifestation is there. Only one cranial of nuclear manifestation is there. That is your human facial palsy is always there. Why? Because your lower motor facial nuclei have only a contralateral supply. It doesn't have a ipsilateral supply. That's why when your one side of brain is damaged, only one cranial nuclear manifestations are there. That is your LM. That is your lower part of cranial nucleus damage, which result in your UMN facial palsy. So, see this diagram. If this is your midbrain, Yeah, my audio is coming. What else, right? Yeah. So sorry for this interpretation. Huh? Okay, everyone. So shall we go further? So okay. So we are we are at we are at now midbrain. Okay. So if this is your midbrain and this is your pons. Okay, everyone. And suppose this is your medulla. Okay. Now, if this is your cerebral hemisphere, this is your so this is your cerebral hemisphere. Okay. Done. Now, see, this is your midbrain. Here, third, fourth, and fourth nuclei. Third nerve nuclei. This is your fourth nerve nuclei. Now, if from here your corticobulbar tract is coming, okay, and from here other corticobulbar tract is coming. Done. So this third nerve nuclei is getting your contralateral supply, and it is getting your ipsilateral supply as well as. It is getting your ipsilateral supply as well as. Same happen for this. This third nuclei which is on left side, it is getting supply from this side also, and it is getting supply from this side also. So both nuclei, so nuclei has a ipsilateral as well as a contralateral supply. Has a ipsilateral as well as a contralateral supply. Okay. So every nuclei in your brainstem has a ipsilateral as well as contralateral supply. Except this is your seventh nerve nuclei. Okay. This is seventh nerve nuclei. This is its upper part, and this is its lower part. This lower part has only supply from this contralateral corticobulbar. It has supply from this only contralateral part. So if suppose I get a stroke of left side, only I will get a right side hemiplegia to the corticospinal tract, that is okay. And I will get the manifestation of the lower part of cranial seventh nerve, that is UMN facial palsy. But my all other cranial nuclei will don't have any palsy because they will be supplied by the other contralateral also. So if you get a stroke, if you are getting a stroke, that is unilateral. That is unilateral. So your cranial nerve nuclei, your cranial nerve nuclei will be spared, because they all have a other supply also. They all have a other part supply also. They all have the other part supply also, except your seventh nuclei. That also lower part. That also a lower part. So only and only if there is a bilateral stroke present, that means damage to both the cerebral hemisphere. That means damage to both the cerebral hemisphere. Only then there will be damage to cranial nerve nuclei. Only then there will be damage to the cranial nerve nuclei. Okay, just okay with this concept. Just give me a thumbs up if you understood that the corticobulbar tract, which are controlling the cranial nerve nuclei, they will be affected only when there is a bilateral stroke. Because in a unilateral stroke, they have a supply from other corticobulbar tract also, so they will get their supply. But if there is a bilateral stroke, both side corticobulbar tract is damaged, then these cranial nerve nuclei, which were under the control of corticobulbar tract, will be free from the control of corticobulbar tract. Okay. And what do you understand by term bilateral stroke? Bilateral stroke means there will be quadriparesis. So, if there is a patient of quadriparesis, then you will suspect pseudobulbar palsy. If you are suspecting a pseudobulbar palsy in a stroke patient, then there must be quadriparesis. In hemiplegia, paraplegia, it can't happen. So, if you are suspecting pseudobulbar palsy in a stroke patient, it should be a bilateral stroke, which should be present with quadriparesis. Yeah, Sharma Puneet, hello. But you are very late. Okay? Then only there will be quadriparesis. So, then it will result into pseudobulbar palsy. Due to damage of bilateral corticobulbar tract. Okay, everyone? Everyone okay with this concept? Just tell me in comment section. Just give me a thumbs up if you understood that pseudobulbar palsy will only and only happen when there is a Shri, any reason for this, sir? Means why in bilateral stroke this is happening? Yeah, reason of bilateral stroke you are asking. Yeah, Steve, if there is bilateral damage, so there must be suppose there is a bilateral MCA territory stroke. Okay. So bilateral MCA, right side, left side, both will be damaged. And if both will be damaged, so both corticospinal tract will go. And if right will go, left hemiplegia will come. And if left will gone, then right hemiplegia will come. So there will be complete plegia of both the sides. Then there will be quadriparesis. And in quadriparesis only, the both corticospinal tract will also be gone, because bilateral cerebral stroke is cerebral hemisphere are damaged. And if bilateral corticobulbar tract are gone, then only your pseudobulbar palsy will manifest. So if you are suspecting a pseudobulbar palsy in a patient who has a stroke, because there are other conditions of pseudobulbar palsy, there are other conditions also. We will discuss about them also. But if in a patient stroke, you are thinking of pseudobulbar palsy, you should always think of bilateral stroke which presents with quadriparesis. Okay, everyone?
Yeah, Shri, quadriplegia, quadriparesis. Quadriparesis mean incomplete paralysis, and quadriplegia means complete paralysis. Only this. But it will be only when there is a quadriplegia or quadriparesis. Okay, Shri. So now, if there is now if there is pseudobulbar palsy, what does it mean? It means UMN lesion. It means UMN lesion. And what are the characteristics of UMN lesion? What are the characteristics of UMN lesion? Tone is increased. Reflex is increased. Tone is increased and reflex is increased. So all the reflexes, spasticity, rigidity in extrapyramidal system, spasticity in corticospinal tract. So if tone is increased, reflex is increased, all the cranial nerve reflex, like your gag reflex, like your jaw-jerk reflex, all these reflexes will be increased, and your tone of the muscles will be also be increased. So there will be if tone is increased, there will be a spastic kind of weakness. Plus increase in reflexes. Yeah, Shri, you are right. Okay, everyone. Pseudobulbar palsy, UMN lesion, and your bulbar palsy, your better DTR means deep tendon reflex. Your reflex will be increased. We have discussed in this in detail in UMN versus LMN lesion class also. Your tone will be increased. Your reflexes that are your deep tendon reflexes will be increased. Your power will be decreased. But compared to LMN lesion, power is less decreased in UMN lesion. Compared to LMN lesion, power is less decreased in UMN lesion. Okay. And if Shri, you are having any doubt further in UMN versus LMN lesion, you can see my UMN versus LMN lecture. It is present in this in the channel. In this channel there is a series of Harrison based series. In this my all lectures are present. Okay, beta Shri. There is a playlist of Harrison based series in which you can see all my lectures. So bulbar palsy, it is a element type of lesion. Bulbar palsy is an element type of lesion. So there will be tone decreased. Reflex will be decreased. So there will be what kind of weakness? There will be a flaccid weakness. Flaccid weakness with decreased reflex. Flaccid weakness with decreased reflex. Okay. And with LML lesion, what happens? There will be atrophy of muscles. Atrophy of muscles. And which muscles? Tongue muscle atrophy. And very good. There will be fasciculation and fibrillations also. There will be fasciculation and fibrillations also. There will be fasciculation and fibrillation also. Okay, everyone. Shall we move forward now? Now see, what is the difference between bulbar and pseudobulbar palsy? Bulbar palsy are lower motor neuron lesion affecting cranial nerve. More precisely, you can say 9 to 12. Some book mention 8 to 12 also. There will be flaccid paralysis of the pharynx and larynx. ठीक है? Pseudobulbar palsy, a bilateral upper motor neuron. What? Bilateral. There will be spastic paralysis of the pharynx and larynx. Okay? Now, just tell me the cause of pseudobulbar palsy. We will discuss one by one. First, tell me the cause of pseudobulbar palsy. Start. Tell me the cause of pseudobulbar palsy, one by one. What all are the cause of pseudobulbar palsy? stroke. Which kind of stroke? Which kind of stroke? Which kind of stroke? Not every stroke leads to. Which kind of strokes? It is bilateral stroke. It is bilateral stroke, and that stroke should be above medulla. Above medulla. No. It can be ischemic cerebral. That is different issue. It has to be a bilateral stroke to be pseudobulbar palsy. That is the most important thing. And it should be above medulla, because if stroke is involving medulla, then it will convert into bulbar palsy. So the stroke should be above medulla. Okay, stroke should be above medulla first. Other, we all know that there is a disease, that is your MND. That is your MND, motor neuron disease. Your motor neuron disease. This disease can involve anything. If it involves anterior horn cell, it will be LMN type. If it involves neurons coming from cerebral cortex, that is your UMN, it can be pseudobulbar. So MND can be pseudobulbar as well as bulbar. It depends on which neuron or which nuclei it involves. It depends on which neuron and which nuclei it involves. No, Sharma, it happens in. I will come on this topic also. Wait a minute. We are coming on this topic also. In MND, it can be both. It can be both pseudobulbar as well as bulbar. Depends on the area which, if it including nuclei of cerebral cortex, it will be pseudobulbar. If it is involving anterior horn cells, nuclei of anterior horn cells in spinal cord, it will be bulbar. Okay. Other thing. Now, Shirley was saying to us that it can be a multiple sclerosis also. Multiple sclerosis also. And in this class, we also have to discuss about multiple sclerosis. In this class, we also have to discuss about multiple sclerosis. So I will just give you overview. Then after completing pseudobulbar and bulbar, we will discuss multiple sclerosis. In multiple sclerosis, what is happening? There is demyelination. There is demyelination of your central nervous system. There is demyelination of central nervous system. So if this tract which are coming from cerebral cortex, if they are demyelinated, what will happen? There will be a corticobulbar tract. And multiple sclerosis is bilateral all the time. It is bilateral. So if there is a demyelination of corticobulbar tract, how it will be present? It will present as pseudobulbar palsy. Okay. It will present as pseudobulbar palsy. Demyelination of central nervous system. Demyelination of central nervous system. Yeah. Amyotrophic lateral sclerosis is a type of a motor neuron disease. Amyotrophic lateral sclerosis is a type of a motor neuron disease. We will discuss this on it. Okay. But other fourth, it can be a high brainstem tumor. A high brainstem tumor that is above medulla. Above medulla. So if there is a tumor above medulla, due to which your corticobulbar tract are getting compromised, it results into pseudobulbar palsy. Other is your central pontine myelinosis. Other is your central pontine myelinosis. And just tell me, in which condition you see this condition, central pontine myelinosis? In which condition you see central pontine myelinosis? Just tell me in comment section. In which condition you see central pontine myelinosis? Just tell me in comment section. Hyponatremia, rapid correction. Very good. If there is a patient of hyponatremia and if you correct very rapidly, sodium, it results in central content melanosis, and it happens in pons. If it is happening in pons, your pons is above medulla, so it will result into a pseudo-bulbar palsy-like feature. So when we are studying central content melanosis in hyponatremia, we see in central content melanosis, it is pseudo-bulbar palsy-like feature plus increase in deep tendon reflexes plus Babinski sign is present. Okay, everyone. Very good. 6. In last class, we have studied your small vessel disease. Your small vessel disease. Your small vessel disease. Because your small vessel disease, it affects the white matter. It affects the white matter. It can be due to a lacunar infarct or it can be a cardiac disease. Either it can be due to lacunar infarcts or it can be a cardiac disease. As small vessel disease, it affects the white matter of brain. It affects the white matter of brain. And white matter is tracts. White matter is tracts. So corticobulbar tracts are made of white matter tracts. So if small vessel diseases are there, it will also result into pseudobulbar palsy. It will also result into a pseudobulbar palsy. So anyone having any doubt in the cause of pseudobulbar palsy, just tell me in comment section. Anyone having any doubt in the cause of pseudobulbar palsy, just tell me in comment section. If anyone is having any doubt in this, I will repeat. Just tell me if all of you are comfortable with the cause of pseudobulbar palsy. See, causes of pseudobulbar palsy, it can be vascular, that is your bilateral stroke, double hemiplegia, that is your quadriplegia. Done, sir. It can be encephalitis. If it is a neoplastic, if it is a malignancy, it can be a mid-brainstem tumors. It can be a mid-brainstem tumors. It can be a mid-brainstem tumors. Okay, everyone? It can be a demyelinating disease like multiple sclerosis, or it can be a degenerative disease, that is your MND. If MND is involving nuclei of cerebral cortex, it will affect the corticobulbar tract because corticobulbar tracts originate from cerebral cortex. And if MND involves anterior horn cells in spinal cord, it will be LMN. If MND involves a cranial of nuclei of brainstem, it will be a bulbar palsy. Okay, everyone? Shall we move further? Shall we move further, everyone? Just tell me in comment section. Now, shall we move further, beta? So, we all know that in pseudobulbar palsy, what will be the clinical features? There will be increase in reflex. There will be increase in reflex and plus a spastic tongue because all muscles will be spastic as it is human lesion. So, what are the reflexes? What all are the reflexes which will be increased? So, see, starts with your gag reflex. See, this is your gag reflex, which is by 9th and 10th cranial nerves, which are by 9th and 10th cranial nerves. Your 9th is sensory. Your 9th is sensory and 10th is motor. So, when you are touching the posterior pharyngeal wall, there will be a sudden cough. There will be a cough. But this cough will be absent in your bulbar palsy, which is element. But this will be present in pseudobulbar palsy, and in pseudobulbar palsy, it will be exaggerated. It will be exaggerated. It will be increased. It will be increased. But it will be absent in your element type. It will be absent in your element type. That is your gag reflex. So, your gag reflex, that is your cough reflex, your gag reflex will be increased. Now we will come to other reflex, that is your jaw jerk. That is your jaw jerk. Jaw jerk is done with the help of your fifth nerve. Your fifth nerve is present in pons. So, if the lesion is above pons, suppose if the lesion is above pons, then this jaw jerk will be increased. This jaw jerk will be increased. So, for pseudobulbar palsy is there, and that also above pons level, because jaw jerk is fifth nerve is at the pons. So, if it is above the pons, normally, beta, normally in normal patient, your jaw jerk is absent. Your jaw jerk is absent. In normal patient, jaw jerk is absent. But if it is present or increased, it means pseudobulbar palsy, that also above pons. Pseudobulbar palsy, that also above pons. And what is the characteristic of this jaw jerk reflex? That the sensory as well as motor, both components are carried by the fifth nerve. So it is a both are carried by the fifth nerve. See, efferent travel through the mandibular nerve, and afferent, they also travel through the mandibular nerve. So both afferent and efferent, both are done with the help of only one nerve, that is your mandibular nerve. So you will ask the patient to open the mouth a little bit, then you will place your finger and you will be, with the hammer, you will be pressing your finger, and there will be a sudden jerk. There will be a sudden jerk. It means jaw jerk is positive. It means jaw jerk is a positive, and your jaw jerk is present in pseudobulbar palsy. Your jaw jerk is present in pseudobulbar palsy. So there will be a positive jaw jerk reflex. A positive jaw jerk reflex. ठीक है एवरीवन? So दोनों रिफ्लेक्स समझ में आ गई? गैग रिफ्लेक्स, jaw jerk reflex, they both will be increased in pseudobulbar palsy because it is in a UMN type of lesion, and in UMN all the reflexes are increased. Normally jaw jerk is absent. Not in normal jaw jerk is absent, but in pseudobulbar palsy jaw jerk will be present, and gag reflex is present normal also, but in element will be absent, and in pseudobulbar palsy it will be increased. Okay everyone, shall we move further now? Just tell me in comment section if everyone is okay, then we will move further. Is everyone okay till now? Any doubt in jaw jerk? Okay, so after completing this reflex, we will come to the causes of bulbar palsy. We will see the causes of bulbar palsy. Causes of bulbar palsy. So now everyone, tell me the causes of bulbar palsy one by one. Tell me the causes of bulbar palsy one by one. Tell me the causes of bulbar palsy. Trauma to brainstem. No, beta, it is wrong. It is not trauma to brainstem. You have to be precise. It is to medulla. A problem in medulla. Maybe a stroke. Maybe a stroke. Or here can be a syringobulbar, a spinal cord cavity which has expanded till medulla. Normally, syringomyelia is at cervical cord level. If the bulbar part, that is, it has gone to medulla, then also there will be a bulbar palsy. Other is your MND. We all know if MND affects the cranial nerve nuclei, the cranial nerve nuclei of medulla, it will result into, yeah, Sharma, please. It can be poliomyelitis also. Yeah, very good. Other. So see, if I draw this diagram, see this diagram. If this is pons and this is medulla, and if I draw this diagram, and from medulla, these nerves are coming. These nerves are coming, and this nerve will innervate this tongue. Suppose this is tongue. This nerve will go further, and there will be a NMJ junction. A neuron junction is there. So if there is a bulbar palsy, so there can be damage at first. There can be damage and in medulla. We have studied. There can be damage in these neurons. That is your M and D. There can be damage in your M and D. Third, there can be damage in your nerves. So, which all things are damaging nerve? That is your Guillain-Barré syndrome. Guillain-Barré syndrome का भाई कौन है? Multiple sclerosis. Multiple sclerosis is demyelination at the CNS, and GBS is demyelination at PNS. Demyelination at peripheral nervous system. So, demyelination में भाई बहन कौन है? Multiple sclerosis and Guillain-Barré syndrome. Guillain-Barré बाहर, MS अंदर. MS at CNS, GBS at PNS. GBS at PNS. Other can be your Lyme disease. A tick-borne infection, which also affects your nerves. It do neuropathy. Other is your Lyme disease. And tell me the condition which will affect the neuromuscular junction. Tell me the condition which will affect the neuromuscular junction. Tell me the condition which will affect the neuromuscular junction. It will be your myasthenia. Very good. It can be your myasthenia gravis. It can be your myasthenia gravis. Very good. It can be your myasthenia gravis. Very good. Now, before we move further, see this bulbar palsy. Vascular can be a vertobacillar insufficiency, that is stroke at medulla level. It can be inflammatory, that is your diphtheria or your polio or your GBS. That can be neoplastic, brainstem tumor, means medulla tumor, or it can be degenerative like your MND. Now, before we move further, we will study other concept like your other concept. So there is something known as your pseudo-bulbar effect. That is your pseudo-bulbar effect. So can anyone tell me what do you understand by the term pseudo-bulbar effect? It is seen in pseudo-bulbar palsy. So can anyone tell me what do you understand by the term pseudo-bulbar effect? Anyone has listened this term before this? Have you ever listened the term pseudo-bulbar effect? Anyone? Anyone? Anyone has any understanding about pseudo-bulbar effect? See, it is seen in pseudo-bulbar palsy as your human fibers are not working. Your human fibers are not working. Okay, sir, our human fibers are not working. So, what will happen? Your element fibers will fire. Now, as your human fibers are not working, what does human do? What does human do? Human first controls the element fiber, and it what it does that it makes the element fibers fire accurately such that it controls that situation. It controls element fiber and make them act according to the situation. Human fibers control the element fiber such that their kinetic, their melody is maintained. Their kinetic and their melody is maintained. Smoothness is maintained such that element fire appropriately fires. Element fires appropriate fire. Now human fibers are not there, so element fibers will all time fire. Fiber, which will result in, and I have told you that these element fibers, as they are concerned with the emotional component also, so there will be emotional outbreak. Which is incongruent to the mood, which is incongruent to the mood. Okay. So suppose these patients can't control their emotional aspect. So suppose if they are in ward and they are lying, so they will start suddenly crying and they will cry for very long, for 20-30 minutes without any reason. If they are laughing, they will laugh without any reason. They don't know they are suffering from problem, but they will laugh without any problem. If you say a normal sentence to them and they start crying, they will cry up to 10 to 20 minutes and you will like, why they are so much crying? Because their emotional outbreak is incongruent to their mood. So this term is known as pseudo-bulbar effect. Yeah, uncontrolled or inappropriate laughing or cry, which generally we see in pseudobulbar palsy patient. Okay everyone. So pseudobulbar palsy में क्या मिलेगा? Pseudobulbar effect. ठीक है everyone. Now what we see that your dysphagia, your dysphagia, your dysphonia, your dysarthria, your dysarthria, and your hypernasality, your hypernasality. This will be present in both the condition. That is your bulbar as well as pseudobulbar. Because in the end, both are affecting the 9, 10, 11, 12 nerves. But they will be more severe in case of bulbar palsy. There will be more severe in case of bulbar palsy. And you will get a hypernasality voice. A voice which has a twang of noise. A voice which has a twang of your nose. ठीक है, it will sound like कि आवाज नाक से आ रही, जैसे क्या करना है, क्या करना है. See the voice nasality, yeah, like Shrisham, yeah, you are right. Okay, so there will be nasality. And why did this is coming? Because we know that there is soft palate, and this soft palate leads to distribution of voice in oral cavity and in nasal cavity by its movement. So soft palate moves and it distributes voice in oral as well as nasal cavity. But if there is bulbar palsy, can soft palate move? No. Now it can't move. So if it can't move, your maximum voice is going through nasal cavity. Your maximum voice is going through nasal cavity. That's why there is hypernasality. Okay, everyone, got this concept? Your dysphagia, dysphonia, dysarthria, and hypernasality will be present in both the condition. But it will be more severe in case of bulbar palsy as compared to pseudobulbar palsy. Okay. Now, yeah. So now we will come to the difference between pseudobulbar palsy and bulbar palsy. So everyone just tell me the differences. Pseudobulbar and your bulbar palsy. So everyone tell me the differences. So your first difference is that reflexes will be increased, and in bulbar reflexes will be absent. Okay, everyone? Done? Second, most important, there will be a pseudo-bulbar effect. There will be a pseudo-bulbar effect. And here it will be absent. Yeah, bulbar is UMN. Sorry, pseudo-bulbar is UMN and bulbar is your LMN. Bulbar is your LMN. Other difference, can you tell me the other differences? What all are, will be the other differences? Anyone? So, in UMN, what kind of tongue will be there? In UMN, what kind of tongue will be there? There will be a spastic tongue. There will be a spastic and small tongue. But in bulbar, it will be a flaccid tongue. It will be a flaccid tongue with fasciculations. With fasciculations. So, if there is a patient and he opens his mouth and there you can see fasciculation, it means it's a bulbar palsy. It means it is a bulbar palsy. Within 1 minute, you can tell. Just see his tongue. If patient is able to move tongue first, and if there is atrophy of tongue, and if there are fasciculation present, it means it is a bulbar palsy. And if it is a spastic and small tongue, so if you tell the patient do these kinds of movement up and down, he will be not be able to do these kinds of movement because tongue is spastic. Okay, everyone. Because tongue is spastic, he will be not be able to these kinds of movements. So in LMN, there will be flaccid and fasciculations will be present and tongue will be atrophied. So if atrophy tongue is there, fasciculation there, it is a bulbar palsy. If reflexes are decreased, it is bulbar palsy. If it is spastic tongue and patient, you are saying patient to move tongue and he is not able to move tongue, it is pseudo-bulbar palsy. Okay, everyone? Got this concept? No. Now we will come to other thing. Now, in both of these conditions, there is dysarthria. In both of these conditions, there is dysarthria. In both of these conditions, there is dysarthria. But here is flaccid and here is spastic dysarthria. Here is spastic dysarthria. So, how we will get to know it is flaccid or it is spastic? See, we all know that there is your seventh nerve. Okay, there is your ninth and 10th nerve, and there is your 12th nerve. Okay, both of these nerves helps us in articulation. Seventh nerve supply your lips. Ninth and 10th supply your soft palate, and your 12th nerve supply your tongue. Okay, so with the help of your lips, that is your labials. That is your labials. So what kind of word you can form with the help of lips? Like P, P, C, P, B. We are formed with the help of lips. So it will be words like P, P. What words are formed with the help of your soft palate? These are your ka, kha, ga. Your ka, ha, and ga. And with the tongue, ta, da, na. See, when you have to say ta, da, na, you have to use your tongue. Ta, da, na. So it is ta. Ta, dha, na. Okay. So in seventh nerve, lips are damaged, problem will be in B and P. If 9th and 10th are damaged, there will be problem ka, kha, ga, ka, ha, ga. With the soft palate. In 12th nerve, tongue is damaged, there will be ta, da, na. Okay. Now, suppose if the patient is having bulbar pulse, if a patient is having bulbar pulse, and there will be a placid dysarthria, okay, but it will depends na कि bulbar palsy कौन सी nerve की है. If it is involving 9th and 10th nerve, there will be difficulty in only in kakhaga. If it is involving only 12th nerve, then there will be difficulty in tadhana only. And if it is involving only 7th nerve, then there will be problem in lips, P, B and P only. So when it comes to dysarthria and bulbar palsy, it depends on the nerve involved. It depends on the nerve involved, and problem will be in that words only, and problem will be in that words only. But when we compare it to spastic dysarthria, in this all nerves are affected. Now suppose if I am a patient with spastic dysarthria, can I move my tongue? No, I can't move my tongue. So I have to put a lot of efforts to make words. Suppose I want to say dysarthria, I am putting efforts. So when you put efforts, and suddenly something comes out, so what will happen? Everything will come in a collider manner. Everything will come in a collide and continuous manner. So your words will be colliding with each other. Your words will be colliding with each other. They will be in a continuous manner and they will be overlapping with each other. So if I want to say dysarthria, it will like dysarthria. If suppose I am repeating, if I want to say dysarthria, it will be effortful. And words will come in a continuous manner. They will overlap each other. So it will like dysarthria. Okay, everyone got this? If not, just tell me, I will repeat. In spastic dysarthria, it will be tough to speak. It will be a effortful speak. And the syllabi will run into each other. Everyone got this? Anyone having any problem? How do you will know it is spastic dysarthria or it is a flaccid dysarthria? Just tell me in comment section. Anyone having any problem? No, it's not like singing. Got this? Flaccid dysarthria will depend on the nerves. And if nerves are involved, only a particular syllabi that nerves involved, it will be involved. Like BP, if it is 7, Kakaga, if it's soft palate. But in spastic, it will be tough to speak. All the syllabi which are coming, they will collide with each other because it is an effortful speech. Okay? No. Yeah, Rishali. If you are putting effort in something, the thing will come in a continuous and a effortful and colloidal manner. So like fast forward kar diya. Very good. Now, when it come to bulbar, there is nasal regurgitation. And chances of choking are there because your gag reflex is not working. Properly. Your gag reflex is not working properly. Okay, and more hypernasality will be present in bulbar palsy. It is like you are speaking from your nose. Suppose I am speaking gag. If I have to speak reflex from nose, reflex. So there is nasal twang. There is nasal twang. Okay, everyone. There is nasal twang. It will be present more in bulbar as compared to pseudo-bulbar. So, see, difference between pseudo-bulbar and bulbar palsy. Your gag will be increased. it will be absent bulbar. Your tongue will be here spastic, here will be wasted and fasciculation. Your jaw jerk will be increased, here will be absent normal. Here speech is spasticity, here it is nasal. Limbs are UMN sign, LMN sign. Emotions are labile. Why? Because pseudo-bulbar effect is there. Here, there is no pseudo-bulbar effect. Causes we have noted bilateral CVA, MS and MND. In bulbar, it is MND, GB syndrome, poliomyelitis and brainstem infarction. Brainstem infection. Okay, everyone? किसी को कोई डाउट यहाँ तक? Shall we move forward? Anyone having? Okay, done. Now, as Puneet has told, na, we will discuss something about that is your motor neuron disease. That is your motor neuron disease, and especially motor neuron disease we'll discuss about that is your amyotrophic. Rishali, yeah. There is a amyotrophic lateral sclerosis. Okay. Okay. Now in M&D, what can be affected? First, there can be your anterior horn cell in gray matter. Anterior horn cell in gray matter of spinal cord. And this is element type. ये कैसा है? Element की तरह. ये देखो, ये spinal cord. Done. And this from here this anterior horn cells are coming and they are going to muscle. ठीक है? So if AHC in anterior horn cell affected, it is like element. Other is your cranial nerve nuclei. Cranial nerve nuclei. Third are your corticobulbar tract, and fourth is your corticospinal tract. Fourth is your corticospinal tract, and they are like your UMN lesion. They are like your UMN lesion, and they are like your LMN lesion. So in this condition, it can be LMN as well as it can be a UMN. It can be a LMN or UMN. Okay. So what you can get? You can get fasciculation as well as decreased reflex. As well as in some area you can get increased reflex also. As well as you can get increased reflex in some places also. Because it is a mixture. And what we have seen that in these kinds of patients, 40% have bulbar palsy and 25% have pseudo-bulbar palsy. Okay. Now, in motor neuron disease, your anterior horn cell canal nuclei affected, it is your LMN. If corticobulbar and corticospinal are involved, it is your UMN. If in this condition, suppose if in amyotrophic lateral sclerosis, suppose your corticospinal tract are involved, so if CST fibers are affected, okay, so CST fibers are, they passes through the lateral column of, see this diagram, your corticospinal tract, it passes through the lateral column of spinal cord. It passes through the lateral column of spinal cord, which is white matter, because in spinal cord, gray matter is present inside, but white matter is outside. Your white matter is outside. So damage is corticospinal tract is there. Suppose if damage in corticospinal tract is there, and your corticospinal tract passes through the lateral part of your spinal cord, that is white matter. So if CST fibers are damaged, so your lateral column of white matter your lateral column of white matter of spinal cord. There is degeneration, and there will be gliosis and sclerosis. There will be gliosis and sclerosis because your CST fiber passes through the lateral column of white matter of spinal cord, and due to their degeneration, there will be gliosis and sclerosis of this area. There will be gliosis and sclerosis of this area. Okay, everyone. Because you can see in this diagram, in spinal cord, the cortical spinal tract passes through the lateral white column of spinal cord. So if they pass through the lateral white column of spinal cord, and this part is involved, so there you will find the gliosis and sclerosis in this area. You will find the gliosis and sclerosis in this area. And if there is LMN involvement, suppose if there is LMN involvement of AHC, what you will get? You will get wasting of muscle. Wasting of muscle. Okay. Now, we all know name is amyotrophic lateral sclerosis. What is this name? Amyotrophic lateral sclerosis. So, what do you understand by myotropic? It means muscle wasting. It means muscle wasting, which is your due to LMN lesion. And what do you understand by the meaning this lateral sclerosis? We all know the corticospinal tract, it passes through the lateral column of spinal cord. It passes through the lateral column of spinal cord. Within 20 minutes, we are finishing. Okay? It passes through the lateral column of spinal cord. So, it means UMN. That's why we gave the name amyotrophic lateral sclerosis. Everyone understood what is the name behind this amyotrophic lateral sclerosis? Amyotrophic means muscle wasting because it is an LMN lesion. And when we say lateral sclerosis, because your corticospinal tract passes through the lateral column of your spinal cord. Your corticospinal tract passes through the lateral column of white matter of spinal cord. So there is lateral sclerosis. That's why we gave the term amyotrophic lateral sclerosis. Everyone, till now, any doubt? Anyone has understood the meaning of this name, amyotrophic lateral sclerosis? Shall we move forward then? Everyone has understood the meaning of term amyotrophic lateral sclerosis? Just tell me in comment section. amyotrophic मतलब मसल वेस्टिंग एंड लेटरल स्क्लेरोसिस मतलब क्योंकि कॉर्टिकोस्पाइनल ट्रैक्ट वो कहां से जा रहा है, वो लेटरल व्हाइट मैटर स्पाइनल कॉर्ड से जा रहा है, इसलिए देयर इज स्क्लेरोसिस. ओके, नाउ इन ALS one thing we should remember that ALS does not involve your sensory system, your autonomic symptom, your bowel and bladder, and your extraocular muscles and your extraocular muscles. ठीक है? Yeah. So always remember that your ALS does not involve your sensory system, autonomic symptom, bowel bladder, and extraocular muscle. Okay, everyone. So here we have finished with the pseudo-bulbar and bulbar palsy. Anyone having any doubt? Then we will move on to the last part of this lecture, that is difference between multiple sclerosis and small vessel white matter disease. So everyone is okay till now? Shall we move forward, beta? Shall we move forward? Okay. Now, before we move forward, just see this diagram. This is in a MRI image. In this MRI image, we can see some white matter hyperintensities. We can see some white matter hyperintensities. These are the hyperintensities of your corticospinal tract. These are the hyperintensities of your corticospinal tract in amyotrophic lateral sclerosis. In amyotrophic lateral sclerosis. Okay. So now we'll move further and we will move to the last part of class, that is multiple sclerosis. So now anyone can tell me the definition of multiple sclerosis? Just tell me the definition of multiple sclerosis. First, we all know that it is a disease of central nervous system. We all know this thing, one thing, that it is a disease of a central nervous system. And it is a immune mediated demyelination of white matter. It is immune demyelination of white matter. And previously it was thought that it only involves white matter. Previously, our thought was that it only involves white matter. But now our thought regarding multiple sclerosis is changing, and some are saying that it also involves some part of gray matter also. Okay. So earlier our concept was that it only involves white matter. But now our concept is changing, and we are saying that it also involves some part of gray matter. Okay. So it is an immune mediated demyelination of white matter. Okay. If it is demyelination of white matter, there will be gliosis and there will be sclerosis. You all know, if white matter is demyelinated, there will be gliosis and sclerosis. So immune mediated demyelination of white matter, which morphologically present as sclerosed plaque, of white matter, and as a clinical neurological deficit. So it is an immune mediated demyelinating lesion of white matter. Okay, which morphologically present as a sclerosed plaque of white matter, and it is clinically present as a neurological deficit. And the interesting about this is that these plaques and neurological deficit, they present as disseminated in time and space. They present as disseminated in time and space. So what do you mean by time and space? Suppose today plaque was in medulla. And after 2 months it will be in your spinal cord. Suppose today the plaque was in medulla, so 2 months after the plaque will be in spinal cord, and 2 months after it will be in cerebellum. So there is demyelination of white matter, which present as a sclerosed plaque of white matter, which also represent as clinically as neurological deficient. And this plaque or neurological deficient, they are present as disseminated in time and space. What we do mean by disseminated time and space? That suppose this plaque of this lesion today it is in medulla. After 1 or 2 months it may present in spinal cord. After 1 or 2 months it may present in your cerebellum. So it changes with time and space. And with suppose lesion is present today in medulla, so your neurological deficient will be of medulla. If this plaque Suppose this plaque is present in spinal cord, you will get the lesion of spinal cord. So this plaque changes its location according to time and space. Okay, everyone? Are you clear with this concept? Now, before we see the difference between multiple sclerosis and your small vessel eye disease, we will first look into the criteria of multiple sclerosis. We'll first look into the criteria of multiple sclerosis. So see this. If this is a 2017 McDonald's criteria. So what does this say? It says if there are greater than 2 clinical attacks, and 2 lesions on your MR. Okay? If they are greater than 2 clinical attacks or greater than 2 lesions, then it is your MS. Nothing additional we require. But suppose if there are 2 clinical attacks, suppose one attack is today and another attack is after 2 months, and only there is one lesion present in MRI. So we need additional data. In additional data, what we need here? We need DIS. We need disseminated in space. We need additional thing. What is additional thing? It is disseminated in space. So what is disseminated in space? It is greater than 1 T2 lesion. In at least 2 out of the 4 areas of CNS. So 2 by 4. So what are these 4 areas? These are your juxtacortical or intracortical or cortical lesion. It is your periventricular, or it is infratentorial, or if it is spinal cord. So I am repeating again. Normally in multiple sclerosis, we need 2 clinical attacks and 2 lesions. If it is present, then we will label it as multiple sclerosis. Suppose if there is one lesion, so we need some additional criteria. So for this additional criteria will be fulfilled by your DIS, that is disseminated in space. So what do you understand by DIS? It is greater than T2 lesion in at least 2 out of the 4 areas. And what are your 4 areas? These are your juxtacortical, intracortical. These are your periventricular. These are your infratentorial. And this is your spinal cord. Okay. Now see. This is, you can see hyperintensities in the juxtacortical area. You can see hyperintensity in periventricular. We can see hyperintensity in infratentorial. And we can see hyperintensity in spinal cord. See this hyperintensity in spinal cord. See this hyperintensity in infratentorial. That is your infratentorial part. See this periventricular area near this ventricular hyperintensity. See this hyperintensity in juxtacortical. Okay. So can anyone tell me what do you understand by term juxtacortical? Shri, can you tell me what do you understand by term juxtacortical? What do you understand by term? Because in this new criteria, they are saying it can be a juxtacortical or cortical. It can be juxtacortical or cortical. Because now they are saying that in multiple sclerosis, gray matter can also be involved. Juxtacortical means area adjacent to cerebral. No, juxtacortical means area adjacent to cerebral cortex. Area which is just adjacent to cerebral cortex. Yeah, it is adjacent to cerebral cortex. Now see, if this is your brain and this is your cerebral cortex. Are you seeing this? This is your cerebral cortex. This is your cortex. Okay, sir, done. Now this inside will be white matter. And this is your gray matter, that is your cerebral cortex. So I am talking about this area. I am zooming in. I am talking about this area, which is just adjacent. This area, which is just adjacent. To your gray matter, just adjacent. Because when we say subcortex, it is white matter. When we say subcortex, it is white matter only, because it is below the cerebral cortex. But when we are saying juxtacortical, it is area adjacent to cerebral cortex. So it means it involves white matter. It involves white matter as well as gray matter, some part. So juxtacortical and cortical means it involves some part of white matter and gray matter, and it is adjacent to cerebral cortex. But subcortex means purely white matter. See this juxtacortical lesion. You are seeing this juxtacortical. This area. This is your juxtacortical. This is your juxtacortical. And there is something called juxtacortical and U fiber. Now, what we see, what is this U fiber? See, if this is your cerebral cortex, if this is your cerebral cortex, okay. So, if this is one gyri and this is other gyri, and these gyri will be joined with the help of association area, and these association areas are U-shaped. These associations are U-shaped. That's why we give name U fiber. So see, these are your U fibers. These are your U fibers. Okay, everyone. See this diagram. These association areas are your U fibers. You are seeing. These are your U fiber. So U fibers are short association fiber in the brain that connect adjacent gyri. Now, juxtacortical is a broad term. Because juxtacortical can contain U fiber, white matter also, or it can contain other white matters also. समझ रहे हो? Juxtacortical में U fibers तो होते हैं, but other white matters भी होते हैं. इसलिए juxtacortical is a broad term. Inside this come U fiber or other white matter and there is also gray matter in this juxtacortical. Okay, अगर सब कुछ समझ में आ गया juxtacortical U fiber, because this juxtacortical and U fiber, the involvement of juxtacortical and cortical structure and U fiber, it is classical of multiple sclerosis. And it is absent in small vessel white matter disease. So, to differentiate between multiple sclerosis and small vessel white matter disease, we want to see if there is hyperintensity in juxtacortical or not. If it is in juxtacortical, it will be. If it is in juxtacortical cortical, it will be multiple sclerosis, because juxtacortical or cortical is gray and white matter junction adjacent, and it involves U fibers also. But this thing doesn't happen in small vessel white matter disease. So, if hyperintensity is in juxtacortical and U fiber is there, then it is a shore of multiple sclerosis. Okay, everyone. If you have doubt juxtacortical में or U fiber में, just tell me in comment section. If anyone having any doubt in juxtacortical and U fiber, Shiri, any doubt? What do you understand by juxtacortical and U fiber? Okay. So we have done with juxtacortical. Okay. Now suppose if there is only one clinical attack, but two lesions, then we need an additional criteria, that is of DIT, that is disseminated in time. And what is disseminated time? It is a new T2 enhancing lesion on MRI with the baseline scan. Suppose you are doing scan today. So after 2 months, there should be a new lesion. Then we call this as a disseminating time or a new attack. So we need an additional criteria in this type of condition. Now see. See, typically, multiple sclerosis involve your juxtacortical and cortical lesion. It must touch the cortex. That is classical. It also have dorsum fingers. and brainstem lesions are typical, and temporal lobe involvement is classical. Okay, so juxtacortical and cortical lesions are specific for multiple sclerosis. So in this diagram, we can see that in multiple sclerosis patient, there is a juxtacortical lesion, but in small vessel disease, there is a subcortical lesion. It is subcortical. It is not in one juxtacortical structure. It is subcortical, but this subcortical it is also present in multiple sclerosis. So subcortical is present in both. Subcortical is present in both, but juxtacortical is present in MS. That's why it helps us in differentiating multiple sclerosis from small vessel disease. That's how multiple sclerosis helps us in differentiating from small vessel disease. Other, see this. We all know that there are periventricular lesions also. There are periventricular lesions also. That is, suppose if this is your ventricle, perpendicular from ventricular, it will be a ovoid shape. Perpendicular from ventricle, it will be a ovoid shape. So ovoid lesions perpendicular to the ventricle, they are your dorsal fingers. Enhancing lesions, multiple lesions which are adjacent to ventricles. So you can see this diagram. These are the ventricle and these are dorsal fingers like projection. They are dorsal finger like projection in multiple sclerosis patient. Okay, everyone. So now when we come to difference between multiple sclerosis and small vessel disease, corpus callosum is involved. U fiber is classical. Your juxtacortical is only here. Your juxtacortical is only present in multiple sclerosis. Okay. When it's come to temporal lobe, it is only involved in multiple sclerosis, but it is never involved in small vessel disease. Your spinal cord, it can be involved in multiple sclerosis, but is never involved in small vessel disease. Enhancement on ganglion, it can be present if there is acute multiple sclerosis episode. If there is acute inflammatory episode, it can be present in multiple sclerosis. But enhancement, it is absent in small vessel disease. Enhancement is absent in small vessel disease. So it is present in multiple sclerosis patient. Just see other diagram. See this. These are periventricular lesion. In MS, it is dorsal fingers. But in this, they are around over 3 to 15 mm and they are not touching the ventricle. They are not touching the ventricle. When we come to the subcortical part, so in subcortical can be in both SPD and MS, but in MS, it involves the temporal lobe, which help us to differentiate between it from small vessel disease. When we come to white matter hyperintensity, it can be variable, symmetrical, and bilateral, but in multiple sclerosis, it is juxtacortical and U fiber. It is juxtacortical and U fiber. Okay, everyone. Have you got the difference between multiple sclerosis and small vessel disease? किसी को कोई doubt? Just tell me in comment section. Multiple sclerosis में 4 structures are classically involved. That is your juxtacortical and cortical. That is your periventricular, infratemporal, and spinal cord. Your juxtacortical, it is in a structure which is adjacent to cerebral cortex. And now people are saying that in multiple sclerosis also cerebral cortex is also involved. So it is adjacent to gray matter. It involves gray matter plus white matter both. So juxtacortical is a classical feature of multiple sclerosis. And it sometimes it also involves U fiber, which are association areas. Which are association fiber, which connect one gyri with other. So these are characteristic of multiple sclerosis, not of small vessel white matter disease. Okay, Shri, got this? Anyone having any doubt? Anyone having any doubt? Just tell me. Is everyone okay? Okay, so we'll be winding out this lecture and next class we'll be taking up aphasia. Okay, next class will be on aphasia, most probably on Sunday. Okay, everyone? Good night and thank you.